Camera off. Fine. Can't. Camera off. Right. Like it.
Erin is on her way back from California, and as we see, is in the car. All right. We'll give people another couple minutes. People will trickle in, I'm sure, as we go.
Sorry to get your snack cup. Well, because
All right, when are we going? We let people join as they do, so we can have enough time for Jessica um, to sort of give us her formal remarks, and we can engage in questions. So, welcome everybody to our last Implementation Science Working Group webinar for the year. We are delighted to have with us Jessica Haberer from Mass General Hospital. She's an internist and professor of medicine. Her work, oddly, is similar to the work that many of us do, but in a very different context. So she blends behavioral science and implementation science and data science and studies medication adherence, which sounds, again, like a lot of some of us, myself included, but does so in a very different context as in mostly in lower middle income countries, Uganda, Kenya, South Africa, and mostly in the context of HIV and tuberculosis, as opposed to domestically in the context of common chronic diseases. And so she's going to talk to us a little bit about the importance of integrating data science and implementation science for global impact. And we're delighted to have her with us. So Jessica, thanks. The floor is yours, and we look forward to a lively discussion afterwards.
Wonderful. Well, thank you all so much for the opportunity to join you. And thank you for the introduction. I will say that I do study medication adherence, but I'm not going to talk about that at all because I'm a generalist and I embrace that very avidly. And I basically do cool things when they come across my desk or when I seek them out. So this is a new area that I've kind of been delving into in the last several years that goes beyond kind of where I've been for much of my professional life. But I still do love medication adherence. So we can maybe talk about that some other day. All right, so I will share my screen. Sometimes Zoom is trying to defeat me. I had this all loaded up and then it disappeared. That's really strange. Give me 1 second. Oh, there it is. Okay, are you able to see that?
Looks perfect. Thank you.
Okay, excellent. All right. So, I forgot to mention, I don't have any conflicts to disclose, but I am funded primarily by the NIH. And I own some stock in a company that has nothing to do with what we're talking about, but it's called Natera. All right. So, for the outline today, I'm going to give you a brief overview of data science. I think this is something that we're all doing to to some extent, but I want to make sure we're all on the same page because there are lots of different ways to think about data science and different contexts. So I'll give just a quick 101 on that. I know you all know how to do an implementation science, so I won't review any of that, but I do often do this similar lecture for a data science audience. So I'm tailoring it for this context. And then I'll talk about how we're putting this together in a project that I'm partnering with a number of people, primarily at the Haberer University of Science and Technology in Uganda, and then kind of where we're headed in this field. And then we'll look forward to a good conversation with you all. Okay, so a brief data science 101. So I hope these are all, again, very familiar terms to everybody, but I really like this Venn diagram that kind of lays out how I think about all of these different areas, because data science can mean a lot of things. And I remember when I first started doing this about 4 or 5 years ago, it's like, well, that's what science is, right? We all work with data. So how is data science different than clinical epidemiology or anything else that we do? And I think of data science as a bunch of different techniques where we're basically trying to take data that's not really well structured, or a completely unstructured, and we're trying to figure out how to make sense of that, like through algorithms, through visualization, through different types of computing. So that's like the overall area of data science. And then a lot of people are doing different things within that context, like AI, machine learning, and deep learning. And those are much more what, it's probably familiar to us as like a socio-ecological model, where they're sort of nested dolls of different types of data science. So with AI, I'm sure everybody's familiar with ChatGPT and that sort of thing, where basically the software is trying to do some learning to achieve certain goals. And I'm not going to go into, a ton of detail beyond that, but that's just generally how I'm thinking about AI. And then with machine learning, we're looking to be able to do more with the data than we can recognize, so that the algorithms are in a way learning without explicit instructions. And then with deep learning, you're going, as the name implies, like even deeper into the data, into things like neural networks, where you're trying to be able to classify and do more involved analysis with that data. So just to kind of put that out there, though, that's how I'm thinking about all of these terms and some of what we're delving into with the data science project I'll describe. So a lot of people think data science can do many, many things. And I think it's important for us to understand what it can do for us and really what it cannot do for us. And then we'll think about if and how and when we should be implementing all of this research. So I did what a lot of people do with data science is I went to ChatGPT and I asked ChatGPT, what are the top 10 things that data science can do for us? So this is a list. Again, this is generated by ChatGPT, which is essentially a probability engine. It just searches the internet with all of the data that's out there and says what words are most likely to come up at one after another in certain contexts. This is what happens with foundational models. There are much more sophisticated models coming along that are called agentic models that can be more refined. But basically, just looking at the probability out there, you can see that data science can do a lot of things for us. Like it can help us with repetitive tasks. It can help us enhance healthcare, and pay attention to the verbs here because we'll come back to that in a moment. Improve a lot of things we do, boost productivity, again, enhance certain things, strengthen, drive innovation, assist with natural language processing. I'm doing a bunch of other work in that area, through things like Google Translate, but also understanding like WhatsApp messages and other things that can give us a lot of information in many ways. So you can see some of the areas where we're using data science, but it's also important to think about what it doesn't do for us. So again, I asked ChatGPT, what are the top 10 things that data science does not do for us? And as you can see here, it doesn't experience emotion. I think we all know that, like that these are computers. But then you get into like some things that may make us think a little bit more, like it can't make ethical judgments. So when we're thinking about like how are we going to apply all these algorithms we're developing, this is a ethics-free zone. So this is something to keep in our minds. It does not engage in true creativity. It may, going back to these verbs here, it may, enhance, improve, boost, that sort of thing, but it's not actually going to be creative. It can help us understand, certain things. Sorry, it cannot understand certain things. It cannot show intuition. It certainly isn't going to help us with, human relationships or adaptation to unfamiliar situations. That human experience is not something we're getting from data science. Certainly not going to help with social dynamics, accountability, and responsibility. So if we're thinking about data science through the lens of implementation science, I'd like to remember all of these limitations because it's data science is everywhere, whether we recognize it or not. It's not going away. And so these are things that I like to keep in mind as I'm working in this area. So one of the things that comes up a lot in thinking about data science is this issue of bias. And as I've been working with a lot of data scientists who are developing these models and the algorithms and trying to use, the different layers, whether it's AI, machine learning, deep learning, et cetera, is everybody's focused on how accurately we can do whatever those repetitive tasks are. Or if we're going to diagnose something, how do we make the most accurate diagnosis based on what we do day to day? But if what we do day to day is fundamentally flawed, and we're operating in an ethics-free zone, we may end up with really, really good models that are really, really biased because that's how they were developed. So there's this ethics piece that we have to keep in mind with data science. And this bias, can be harmful at the individual level, organizational level, societal level. A huge amount of this bias comes in through things like ChatGPT, which are just so common. They're being used in so many different areas. I do think that the more recent agentic models are going to be a lot better at this, where they're able to contextualize more. But this is, what a lot of people are doing in data science. So let's go to the global context. And when we're applying ChatGPT or Llama, whatever it may be in America, it's operating off of data that's largely relevant to America because that's where a lot of the activity is on the internet and a lot of the content that's driving what's on the internet, or maybe it's in Europe or other places. But a lot of the work I do, as Nitish mentioned, is in partnership with people in sub-Saharan Africa, and they're using all this just like we are. But the data that's informing how they're using these algorithms is not coming from Africa. And this is where that issue of bias really comes in. So I did a little quick and dirty experiment. This is kind of like a back of the envelope sort of analysis. But I went on to PubMed. I'm sure everybody uses PubMed. And I put in the search terms here, data science. And you can see that in the last, 20, 30 years, it's, especially in the last like 10 years, it's just skyrocketing, right? There are over 40,000 publications just with the term data science in there. But when I add Africa after data science, I see this. So similar trends, in terms of like the uptick in the interest in data science, but with Africa included, we're looking at 2%. So if you extrapolate this, and there are other data sources that corroborate this kind of leap I'm making here, but we're only contributing about 2% of the data to data science from the African continent, even though in that context, they're still using the same algorithms, the same approach to data science with data that may or may not be relevant. So this issue of bias becomes very, very concerning. And some of my colleagues at this paper that you see here from PLOS Digital Health that was published in 2022, Leo Celli is the first author, and some of the other people who were involved in this project are also partners of mine in some of the work I'll describe in a minute. But really kind of go into why this is so concerning in global health in particular. I think this applies to pretty much any aspect or application of data science. But in particular, it can be very concerning for the global health context and the inequities that we're seeing in many areas. All right, so now I'm going to tie all of this into implementation science because that's what I think unites all of us on the call today. So why is implementation science so important in this context? So everybody here, I'm sure, has read the Nielsen paper many times from 2015. As I said, I'm not going to do like my usual overview of implementation science for data scientists, but just to kind of make a mirrored comparison here, I'm going to go to these basic principles about implementation science of what it's meant to do. So it's meant to describe or guide translation of research into practice. We want to understand what's going to, explain or understand what the influences are for those implementation outcomes, and we want to evaluate. So what does this look like for data science? So in a parallel way, the way I kind of put it together is that implementation science is going to help us make data science usable and relatable in practice. And when I talk to a lot of data scientists, it's a lot about just what's the algorithm, like how am I going to make this machine learning model work, what is the tech piece of it. But that's the same like trap that we've been in clinical epidemiology or behavioral science, or the other areas that we have been practicing and trying to improve upon with implementation science. It's the same area where we've been for years. And the marriage between data science and implementation science is absent in almost all aspects of data science, at least that I've been exposed to. So number two here is to evaluate the influences and use of algorithms, just like any other intervention. So say you do have a good algorithm that's accurate, hopefully not very biased, something that's going to be beneficial. And I'll talk to you about some of the things that we're doing in this area. Like any other intervention, we want to make sure that we're using it properly. We're getting it into the hands of people for whom it can benefit or create a benefit. And then this issue about bias. So increased use of data science, it's a cyclical feedback loop. So if the more that we can implement good data science that's informed by the environments in which it's being used, the better it is. The less biased it is and the more effective it can be. So in some ways, it's even more important in this context. So I'll tell you a little bit of how I'm applying all of these different areas to the research that I'm focusing on, in data science. So as I mentioned, I work with a university in southwestern Uganda called Haberer University of Science and Technology. Steve has visited us there, so he can maybe add his views on it. He's an advisor for this project. So their university is shortened to MUST, and their logo is Succeed We Must. So it's a bit of a scrappy university. They've only been around about 30 years, but they are just on fire in terms of their commitment to academics, and are just really a pleasure to work with. So as I mentioned, they are in southwestern Uganda. You can see where that is on the map here with the red circle. And this is one of the main buildings at their Chihumuro campus. They have a couple. One's by the hospital, Embury Regional Referral Hospital, and this is another campus focused mostly on the academics. So what are we doing there? So the NIH, as part of a Common Fund initiative a couple of years ago, sponsored the Data Science Initiative for Africa. And so this is a major investment, very unusual for NIH, but where they occasionally will have these common fund programs where many institutes are committed to trying to do something transformational. So this is, over $100 million investment, sponsored by the Fogarty International Center, which is the global health branch of NIH. But many institutes are involved, NHLBI, NIAID, many of them. And what they're trying to do is create the infrastructure to address some of the problems that I mentioned earlier in data science, and create the ability to feed data into data science, whether, again, it's AI, machine learning, deep learning, to make sure that the algorithms that are going to be used on the African continent are informed by data on the African continent. And that benefits everybody in terms of innovation and the way health is influenced through data science in sub-Saharan Africa. So this program has multiple research hubs, training programs, ethical, legal, and social implication programs. As I mentioned, this is an area where ethics is very critical. And then there's a coordinating center. So in 2021, this program began, and we at Embury University are one of the research hubs. And so this is basically a U54. So for those of you who are NIH funded, this is like a couple of R01s with a few pilot projects and some cores that are enabling us to create a data science capacity in Uganda. We are partnering with folks in Ghana and Kenya, and you can see by all the purple upside down, I guess, teardrops on this map here, that there are lots of different hubs, training programs, LCs all across the continent. Some additional R01s were added to this project a couple of years ago, so it's continuing to expand, and we hope it will be renewed for another 5 years. We'll find out shortly to see if that's still with current priorities at NIH in 2025. But as I said, this is a major initiative and investment from NIH. So our project, we call it MUDSRI, which is perhaps an awkward acronym, but it stands for the Haberer University Data Science Research Hub. And as I mentioned, this is a U54, so it is structured for capacity, but with specific applications. So the PI, this is a primary award to Haberer University, which I think is the way global health should be done. So it's not an award to me, it's an award to principal investigators in country addressing areas of interest to them. I'm a supporting PI, but our contact PI is Fred Kakwa, who's a data scientist at MUST. And you can see that there are many, many partners. I won't go through this full structure, for sake of time, but you can see that there are partners here at Mass General, also with Mass Ioneer. There's an administrative core that helps administer this project, but also thinking about the data governance that's really critical in data science and how to move data internationally. There's obviously a data management and analysis core that's central to data science. And then MIT is supporting this work with my colleague Leo Celli, who I mentioned before. So we are working in a couple different areas of algorithm development. This is all sort of united around clinical imaging. So nothing to do with adherence. Again, this is all about clinical images. And we started off with some partners in gynecology, looking at cervical cancer screening, both in Uganda and at Kwame Nkrumah University of Science and Technology in Ghana. We also have a big project on retinopathy, which is one of the leading areas for data science. I'm not really sure exactly why that is, but there's a lot going on there. And so we're partnering with some folks at Mass Ioneer, as well as the COEXA, which is a college of ophthalmology in East, Central, and Southern Africa. And then we have a number of pilot projects where we're trying to expand what we're doing on a smaller scale, working very closely with NIH, and then our scientific advisory board, as you can see, includes Steve. So this is just a few of our members at our recent consortium meeting. It's not everybody involved in the project, but it's just a fantastic group, and I feel very fortunate to be partnering with them. So just to tell you a little bit more about what does this all look like? So how is data science coming together with implementation science in the global context? So when we look at the overall aims of our U54, so this is, again, the overall structure, the overall structure. What we're aiming to do is to integrate multiple institutions, technology companies, NGOs. All of this is meant to advance data science for medical imaging purposes. And we are looking to integrate implementation science with data science to advance clinical impact. So this is a fairly unusual approach to data science, but it's one that I think NIH has really embraced, and they are pushing forward with the renewal that we hope will come for this overall data science initiative. And as I mentioned specifically, what we're doing is developing algorithms for retinal diseases through some eye exams, and I'll show you that a little bit more in a minute. Also looking at cervical cancer screening, which is a very visual diagnosis, and then these other projects. But our focus is on pipeline generation, and I'll talk about why that's so important, particularly for implementation in a moment. So the first project I will tell you about is called AVEMAP, which stands for Automated Visual Evaluation and Geospatial Mapping. So the first aim within this project, which is essentially an R01, is to optimize AVE, or the Automated Visual Evaluation for cervical cancer screening, again, in Uganda and Ghana. And we're creating labeled data sets. So we're getting lots and lots of images. So I'll show you what that looks like in a minute. But we're using biopsy confirmation as well as expert labeling to understand what the cervix looks like with certain pathologies, including how STIs or other conditions might influence that diagnosis. And then we develop the algorithm. So pretty standard data science. But what I think makes this project really cool, in addition just to working with incredible partners, is that we're taking the idea of advancing diagnosis through these algorithms, which can enable lay health workers to make more sophisticated clinical decisions, but we're figuring out when and where and how to implement that algorithm. So it doesn't stop with just the data science piece. And so we've been doing some geospatial mapping, looking at current and 5-year projections with Ministry of Health data to try and figure out, how do we overlay this? So what's the population? How much time does it take to get from one place to another? So that if we're going to deploy these algorithms and make sure that the cameras and everything that needs to be involved are there, it's going to be efficient, effective, and actually implemented and used. So the third aim for this project, I'm sure everybody has seen REAIM before, but we are going to use the visualization with the geospatial mapping as a scale-up plan. And we are not quite at this point yet. We're in year 4 out of 5 for the project. But we're going to be doing the standard stuff, so looking at how many people get screened, how many people are in whom we can avoid invasive disease. How many of the clinics are able to do this, and just learning how to work in the clinics for collecting this data has been incredibly informative for that rollout. And then looking at, fidelity and ultimately sustainability. So here you can see just a little bit of an example of what this looks like on the ground. So this poster is just it's a picture I took on the wall of how they're thinking about ultimately rolling this out. So this needs to be simple. It can't be very, complex if we're asking lay health workers to do it. So from the beginning of algorithm development, we're thinking about how it is going to be deployed. And you can see here in the red oval, this is called a gynocular, which is essentially a camera that can be used during a colposcopic exam or just a basic pelvic exam that can then generate the cervical image that goes into the algorithms. And this is Tom Coney, one of our PIs from Ghana, and a few other members of our team in Uganda. So then the other project is MODRIA, which stands for Multimodal Database with Retinal Imaging and clinical data from the African population. And you can see, a typical retinal image on the right with some of the tomography underneath it. So those are the standard images. And as I mentioned, this is a kind of cutting edge field within data science for diagnostic development. I think partly because, again, ophthalmologists love these cameras. They're really good and they can tell us a lot of information. So Modria is basically creating these deep learning algorithms for posterior segment eye disease. And what we've added on to that to, again, like really embrace the need for implementation is evaluating feasibility, appropriateness, acceptability of these algorithms in real world settings. So I'm sure you recognize these terms from Proctor. So we are putting all of this together. As we speak, we are at the point of having algorithms. We are actually hosting a datathon where people are coming together to work with our data and to try and figure out how to apply this in the local context. So if anybody would like to come to Uganda in February, we will be playing around with this data, but also thinking about this bias issue and how to include equity in what we do for data science. And the way we're structuring this symposium is also trying to further the implementation science, like the emphasis that we're including in this project. So it's not just a bunch of data scientists talking about the algorithms, but we're really including education about the importance of implementation science for the people attending our symposium. And we're making sure that we invite Ministry of Health members, whether that's national, district, or local level. We're including various academic and community members within each discipline. We're bringing the press. We're also bringing industry, like like Google needs to know how we're dealing with limitations of data and how we can think about implementing all of this. Working with companies that are creating things like the gynocular or other equivalents that can be used in low resource settings. And then what we hope to do going forward is with our renewal, if we're able to do this and successful in getting funded, what we're going to really concentrate on in our project 2.0 is the actual implementation. So we're setting up the ability and doing some pilot testing in this last year of the project through AveMap and through Modria. But we recognize that data becomes stale, much like a loaf of bread. If you're a baker, you take it out of the oven, it starts to get stale, and data does the exact same thing. So all these algorithms that we develop within data science science, they often stop right there, and you just have a bunch of data that within a year is useless, because things change, algorithms change, data science changes very, very quickly. So we're focusing on implementation of development and implementation of pipelines, which itself is an important concept that hasn't really taken hold, I think, enough within data science. So that itself will help further our goals of using data science, and not just keeping it in academics, but actually having it influence clinical care. And then we're hoping to create a hub for this kind of algorithm development with clinical images that is fit for the low resource context. I won't get into a lot of the details, but working with imaging is very data heavy. And so we're having to innovate and create things like vector embeddings, which is a way of shrinking the amount of data you need to understand what's happening within an image. And that itself will also further our goals of implementation, because it really reduces the bandwidth and the power that's necessary. So I will stop there. I think I made it exactly half an hour in a teach. Just want to thank the many, many people who are involved in the Data Science Initiative for Africa. We, again, are funded through a U54 mechanism. We're a very large team, so I only showed you a portion of the people we're working with. But this has been a fantastic journey that I've been on in the last several years. Doing this work with the partners in Uganda, Ghana, and Kenya. And I'm happy to open it up for any questions. So
Great. Awesome, Jessica. That was great. Thank you very much. If I can ask Danielle or Julie, whomever's controlling the host, if you just unspotlight Jessica so we can make sure that we can see everybody. So I'm going to take the prerogative to start us off. There's a few questions in the chat, which I'll turn to in just a second, but then invite others to raise their hands and comment and question and add to the conversation. And so, Jessica, what you've talked about is, it's absolutely fascinating. But to me, it reminds me of conversations that I and others have had here, for example, with the FDA in the process of the development of drugs. So before they are actually approved for use and proven to be EBIs, proven to be evidence-based interventions, almost upstream of that. And the idea that we should think about ultimate use at the time of development, as opposed to develop it and then figure it out. It's almost too late at that point. And I'm wondering if you sort of agree with that characterization, whether and how this sort of conversation began at all, because that most people will say, well, why bother until I know that it works?
yeah, I mean, I think that's a really great way to think about it, because yeah, it's almost exactly the same thing. So if we're going to create a ton of algorithms or machine learning approaches that ultimately aren't accomplishing what they're designed to accomplish, then again, why bother? The same thing with being able to use anything that gets regulated. But I think with data science, it's relatively new in figuring out how to implement it. I think one of the big learning points from this whole project, again, we're in year 4 out of 5, it took us 2 or 3 years to even figure out, like, really what were we trying to do? Because it hasn't been done in this way. And it's been a mind shift to think that what we're trying to do is create these pipelines that will enable the capacity to do this, and not just think about, well, we just need to collect a bunch of data, because that's what we always do. And particularly in global health, where the partnerships are often not particularly equitable, and our partners are asked to just collect data for questions that are developed by people like me, or coming from an outside area. And that's not what we're doing here. We're trying to figure out what's going to work in the setting, and figuring out how, like, I think one of the questions here was, like, what kinds of data are we working with? We're working with, the images, but also how to collect data in a way that is feasible to feed the algorithm. Like, how much data does the algorithm need? There may not be, in fact, in most places, there aren't electronic health records. So we have to figure out what kind of data is worth collecting, because that's going to have to be part of the process. So, do you need, location? I don't know, maybe. Do you need, weight and age? And when we go through the process of labeling the images, to know if it's pathology or not, or like what degree of pathology, who's going to do that? Like how do we make that work? Because images, and images in particular, I think are critical within the African context, because there are differences. And the Data Science Initiative for Africa is looking at genomic data, climate data, all different types of data, where there could be very important regional differences. But we have to figure out which data is important, how do we collect it, and all of that, I think, is going to be critical for it ultimately being used. So to your question, yes, I think we're exactly, like at the early, like phase 1, phase 2 kind of equivalent of figuring out what are we trying to do, and thinking about implementation early. I think is so critical for this to actually translate into changing practice, and not just be this like shiny object that everybody talks about.
Great. Awesome. So I think you've not only answered my question, but skillfully Clara and Shafika's at the same time. And so maybe we can open it up. Don, I see your hand. Why don't you fire away?
There we go. Yeah, this is really interesting. My brain tends to parse things into buckets. And so I think there may be two buckets here. I totally get the data science piece. You're going to spend a lot of time trying to figure out what data that's fresh data can be used to inform a powerful algorithm that has good sensitivity and specificity, usability, and so forth. But then there's another piece, which is about implementation research that you highlighted using Proctor's criteria, whatever. Um, but I don't see how what you're doing with the visual algorithm generation is any different than Gene Expert to diagnose antibiotic resistance in TB, where a lot of effort went into it, thousands of strains, lots of testing. And then the whole thing was, how do we make it cheap enough and portable enough and electricity free enough so that people can actually implement it in Africa? So does that make sense, or am I missing something?
I think they're parallel, but they're a little bit distinct. So, like with Gene Expert, I've certainly been to many clinics where Gene Expert is sitting in the corner, dusty because it broke and nobody could fix it. Um, that happens all the time. So it's sort of like a deployment issue. And all of the usual questions about implementation come up. The like trying to figure out, well, why is that machine sitting in the back corner, dusty and not being used? And I think part part of what's a little bit different about what we're doing is we're sort of developing the machine, like in at the same time. So it's not just creating something and then just plopping it wherever it's going to make the most sense based on a variety of criteria, but we're generating the data in the setting where it's going to be used to be reflective of that environment. And that may be specific in the sense of Uganda, or it may be something that's like for East Africa, or maybe the entire continent. But all of that data can to some extent be used to improve on what the service is meant to do. So in some ways it is very similar, but I think this is more embedded in the area. And I think having this project led by Fred and others, who are implementing the research and figuring out how it makes sense in that context is in some ways really beautiful, because it's the way I think global health, should be done. I mean, obviously there's a lot of complexity and not all projects can be done that way. But I think their creation of data with their data for the questions that matter to them, and engaging with the Ministry of Health, with local industry partners, with the people who are running the cloud services and so forth on the continent, figuring out all of that for the ways that they know it can work, and to overcome the barriers that they live with every day. I think that's it's such a better approach than like just plopping a bunch of gene experts, throughout the
Yeah.
country.
So there's still two parts to that. So one of them is a real-time learning system that is constantly deriving data from the context in which it's being
Right.
used, kind of a servo mechanism.
Yeah. Mhm.
And that's really, really important. The other you're saying, which I totally agree, and a lot of uh, technology folks are beginning to understand, better to co-develop the instrument with the people who are likely to use it rather than having Stanford really smart kids come and say,
Yeah.
this is what you need
Yeah.
in an ICU. So I get that part. I still think there's going to be a challenge when your key collaborators are on moving on the next thing, that you still may find the thing sitting in the corner not being used. So that I think that's going to be the challenge, is
Well,
spreading and sustaining it.
yeah, I mean, part of just, I mean, sustainability is hard, right? I think we all struggle with that, but that's part of the goal of including the Ministry of Health, in the implementation and development process. Because if this becomes how they are providing ophthalmology care, that is going to promote sustainability. And I think that that principle applies whether we're in Massachusetts or Uganda. But it's so rarely done. And we'll see if it works or not. It may, we may still end up with a bunch of algorithms that get virtually dusty. But I'm hopeful that it won't be that way.
Awesome. Steve.
Yeah, I'll just say first of all, as somebody who went into Mumbara and saw all this, it was not only incredibly fascinating, but to see Jessica's leadership and facilitation, being a real partner in terms of promoting that particular settings and embracing, owning, running all this is just fabulous and really requires both a terrific scientist, a physician, and a diplomat. So I just wanted to acknowledge. But one thing I was going to say to Don's issue was what was so interesting to me from the standpoint of implementation science is I can't remember the ratio, but it was something like when I was there, when we were there, when we walked around, we met the one ophthalmologist for what, 1.5 million, and the one OBGYN, something like that. So the issue of will it be used is like, there's no way that you can even begin to do the ophthalmological examinations at this level of the population to actually provide the type of diagnostic capabilities without this very cool capacity to have a device that can be used in the field by a community health worker, get the image, send it up to the cloud, put it into the algorithm, which is tailored for that particular, Ugandan population. And yes, figure out, is this progressive, whatever, diabetes, you name the fundoscopic disease, and then the same thing for the issue of cervical cancer. So in a low resource setting, will it be used? It's like, I can't imagine why it wouldn't, because the alternative is so compromised or challenged by the lack of specialty care. So the implementation issue to me is not only about the technology and how do you get it in place and how do you get people to own it, and seeing these wonderfully bright young individuals saying, I'm a data scientist, and going through the classes and learning about how to do this, and I'm an implementation scientist, they would say, but also the issue of how does this directly insinuate itself into public health interventions. And that is like way cool and very much an implementation execution question. How do you insinuate data science, images, algorithms into actual end of point of care to strategize about who is really acute and needs to see the specialist and who's just fine and who has early signs of macular degeneration. So anyways, that to me was the really fascinating public health issue of this marriage between AI, data science, imaging, and implementation science in public health. It's just great project, so fascinating.
Well, thanks for your involvement, Steve. Much appreciated.
It was a joy.
So Jessica, maybe I'll continue on as others think about their questions. You began to touch on the fact that, as an implementation researcher, context is everything. You're working in one specific part of southwestern Uganda. Other parts of Uganda, leave aside other parts of East Africa, leave aside, all the diversity that is Africa, mean that context becomes not the same. And I know that that's not remotely that's I'm sure more than obvious to you, but I'm wondering how you now think about, okay, let's say this works. And so it's the scale up problem when the context becomes difficult. What's different about the African context than maybe different here domestically, or how do you sort of see the roadmap of this?
Like scale up of like these
Let's
algorithms
Yeah,
and
so let's say any of these algos work really well, and you figured out local implementation, and you've demonstrated that. But now it's a question of sort of more, because the problem that Steve describes of
yeah.
one ophthalmologist for 1.5 million people is not unique to southwestern Uganda. It is rife across the entire continent.
Yeah, I mean, I think this is where implementation science gets applied like it does anywhere. Like you have to do the same kind of research to understand like what are the barriers, what does the landscape look like? How do you get ministries to buy into this? All the usual things that we do to try and understand that landscape. I think there are huge issues around data governance. And one of the ways that I think people are thinking about this broader implementation question is ways to simplify the process so that you don't need to recreate everything in every place. And that really quickly becomes challenging with all of the international regulations around moving data. So one of the solutions, which I really like, but is a little bit tricky in the moment, is doing everything in the cloud. And there are clouds that are hosted mostly in South Africa, but there's some I know of in Nairobi, and I imagine in Nigeria, some of the bigger centers. So at least it's regional. But being able to actually do the compute part of it in the cloud, so you don't actually have to transfer data. So if you can figure out how to contribute de-identified data to the cloud, you can work on it in the cloud, get your algorithm, get your, the process that's relevant with your data, and not have to go through data use agreements and all of the legal back and forth that basically kills so many projects, whether it's data science or otherwise. So I'm hoping that there are some innovations around that. And, innovation often comes out of necessity. And some of the things that I was describing, like vector embeddings, are, just again, it's a way of taking complex data and simplifying it through essentially coordinates. And that's something that's nice to do here, but it's absolutely necessary to do when, downloading an image takes, 8 to 10 seconds, which doesn't sound like much, but that, if you're going through thousands and thousands of images, it becomes a non-starter. And so the project, oops, sorry, just 1 second, my computer died. Wait a second to get it back. It does this. Okay, it does this occasion. So, we are trying to innovate around vector embeddings to make the use of clinical imaging easier. So if we are able to figure that out, then other people can use it as well. So I'm hoping that some of the common barriers around resource availability, we can help to innovate in that would make it easier to implement in other places. But as you said, Africa is not monolithic. Like it is incredibly diverse. And what works in South Africa is not going to work in Uganda. And North Africa is entirely different as well. Like there's just so much complexity as there is anywhere. And we definitely shy away from that monolithic Africa. So I think going back to basic principles for implementation science, that's really going to be critical. But I think what we're trying to do in our own work, and as we talk about our work, is what your earlier question was about, and that implementation needs to be part of the development of data science and not an afterthought.
Right. Awesome. I see a question from Julie. Julie, do you want to unmute and just give a little bit of context to your question?
Sure. I was just thinking a little bit more. You talked a lot about, this was really great, by the way. You talked a lot about using, data science to improve maybe more the design and implementation of interventions on some level. And I was wondering if you could talk a little bit about how you see that also helping more on the back end. You mentioned re-aim, and still some of the outcomes you were collecting were kind of things that weren't super complicated to collect on some level. And I'm thinking about having advised at least one person on this call a bit about how to collect data in these sort of low resource settings, and just curious, what your thoughts are a little bit more on that end.
So when you say back end, tell me a little bit more what
Yeah, so the implementation outcomes specifically are things about acceptability, adoption, those sorts of things that, may have been hand collected a bit more in the past. And so I'm wondering the data science piece might fit in with that as well.
So yeah, I was clarifying because backend for us usually means like the code.
I realized that that was a poor use of what I meant there. Yeah.
No, I was just saying that I know how to talk about data science. I do not know how to code at that level. I can do a little bit, but I'm definitely not qualified to talk about the back end of any kind of algorithm development. So, in thinking about like what kinds of data to collect to really understand if we're implementing properly, is that what you're asking about?
Yeah, so implementing properly, exactly, and how the intervention is used on some level too. Yeah.
Yeah, I mean, I think there are a number of complexities that come up. I mean, a lot of it is the same stuff, like we want to know if things are acceptable, we want to know if they're feasible and all of that. But one of the things that I've learned over the years of working in Uganda and a few other contexts, the way people see what we're doing is often quite different. So the average person, like say we want to ask like patients in a clinic, is it acceptable to have um, like a camera diagnose you? Like that might be something that I would ask of somebody in a clinic at Mass General. That's not necessarily going to be relevant in that context because, for one thing, research and clinical medicine are often not distinguishable, to the average person. Like the way that the clinical care is provided, that concept is not commonly understood. So you need to ask about it in the right way. And the process, like the way patients experience the process of care is quite different than what it is at Mass General or something that may be more familiar to us. So I think the way we ask questions about what is acceptable, what is appropriate, needs to take that into consideration. And what is acceptable and appropriate is going to be what is perhaps feasible and gets the care delivered, as Steve was saying. When you're dealing with choices of absolutely nothing, or something that could be supported, that needs to be factored in. Like trying to use the Wiener questions, the four, like aim and I am and
Yeah,
flew.
the AIM questions.
Well,
Yeah.
they don't work. They just don't work. And the translation is a nightmare because those are nuanced, very Western concepts. So you have to take into account what is it like to actually get care, and then thinking about like the health system. Like I know the health systems well in the countries where I've worked, and they're often very hierarchical, and the decisions that may happen at a clinic level are influenced by what happens at the district or what happens at the national level, or maybe what NGO has swept through, like whatever may be driving the way care is delivered. And so that's going to have to be factored in. And so the types of data that you collect around like, the reach or, those kinds of things. The examples I gave you are like the basic stuff, but we haven't gotten into, and like that's the next step of our project is to figure out what that really looks like. And that's why we're trying to engage with the partners now, so that we can ask the right questions and get the right data. I like the geospatial mapping that we're doing because I think that really fits in with the way the ministry is thinking about a lot of allocation of care. So we're trying to adopt approaches that make sense with their decision making, which is going to be somewhat different than the way I would think about it in Boston. Does that answer the question?
Yeah, that's great. I had a relatively informed question and you answered it in a way that was better than my question. So thank you.
Jessica, where you ended, and to some large extent, Julie's question as well, is almost the opposite relationship between implementation research and data science, to the extent that, you are, I think this was framed as data science as the evidence-based intervention. How can we ensure that it is adequately used, acceptable, all the other sort of parameters that of effective implementation, as distinct from data science being the enabler of implementation or being the tool to promote implementation. So, for example, we use a lot of data science reinforcement learning to get people to adhere to their medications,
I
amongst
see.
other
Yeah.
things. And Julie's comment about using data science to collect some of the outcomes. So, can you use large language models to collect outcomes,
Yeah. Yeah.
as opposed to, so there, it just makes me think that there are multi-way directions here, and it seems like your project is in fact doing a bit of both directions, especially with the
Yeah.
geospatial mapping stuff.
Yeah, that's a really cool point. We've definitely been thinking about the former and less about the latter, but yeah, I like that. we can think about that some more.
Awesome. All right, we're coming quickly close to the end of the hour. Any questions for anyone else or other comments? All right, I will bring us to a close. I'll call out Danielle's note in the chat that Carol Lewis will be joining us from NHLBI and next time. So to follow this theme of excellent speakers, Jessica, this was absolutely amazing. Both many congratulations, as Lydia has offered in the chat as well, but also thank you for sharing with us. And we hope that everyone has healthy and happy holidays and a prosperous New Year's.
Great.
Thanks,
Well, thank
everyone.
you
Thanks,
for the
Jessica. Really
opportunity.
excellent.